And joining me now to help explain these changes to prescribing opioids is Dr. Scott Kjelson, assistant professor in the College of Pharmacy at Southeastern University, and Dr. Dennis Patin, pain division chief for the University of Miami Health System. Gentlemen, thank you both for being here. We really appreciate it.
Thank you, Pam. Thank you
All
so
right,
much.
so Dr. Kjelson, let's start with you. Let's kind of unpack what this new law actually means. Let's start with when it comes to patients. What does it mean for somebody who is either on opioids or is being prescribed opioids?
Well, I would like to start with the fact that I believe there's more consistency in the information, and it really hones in on educating our patients. Part of the bill actually is for documentation, and we discussed that a little bit before, but ideally, I think that we have to have better education around this law for all providers in general, and as well case managers, because patients are scared. Patients are a little bit fearful that they feel that the chronic care management may not be addressed properly, and the patients that are legitimate may not be addressed properly, but that is not true. And so I do believe that we need to better educate our patients. So in terms of HB 21 and the law or the ruling, I believe that it is going to help patients in the long run. And I think that it's going to take away the idea that opioids or pain medications in general are just safe, and it really hones in on helping them understand the mechanism as well, and helping them understand what they're really for.
And then talk about some of the restrictions. For example, one of the biggies that really sticks out is this 3-day limit, maybe up to 7 days. Do you think that's really going to help with people becoming addicted to opioids, this restriction?
So I do. I think one of the things is that, I mean, right now we're seeing pharmacists even go to, getting not reported, but having complaints that they're asking physicians to put acute on the prescription. And so one of the ideas or the language that's in the bill right now currently, if you're writing for acute medication, you don't have to put acute. And that's sometimes some of the barriers, that if your prescription doesn't say acute right now, a pharmacist may tell you, hey, I can't fill this right now.
Sure.
So that's the education point that I was making before. But I do think that the 3-day supply is going to help guide individuals that are either dispensing or prescribing. And basically the CDC, DEA, and multiple corporations have kind of gone in that same realm. But I do believe that the relief for the 7-day acute exemption will help a lot with those longer-term pain management.
Dr. Patin, let's talk about that for a moment. This is what you do. You deal with pain management. What does acute actually mean? For somebody who's watching right now and they say, what is the definition of acute?
Well, acute is the expected physiologic timed response to an injury. It could be thermal injury, burn, mechanical, or surgery. And we've all had those sorts of injuries, and we know how long it takes to feel better. It's usually days to a couple weeks. That kind of pain doesn't persist forever. It doesn't go on week after week or month after month. And if it does, it shouldn't be treated with an opioid. It should be referred to a chronic pain specialist so we can use all the tools we have to treat such pain.
So somebody with chronic pain, ongoing pain, like from an accident, an injury, that's somebody who would be prescribed an opioid over somebody. The acute would just be that short period of time. That's what you're saying, correct?
Well, acute pain is very responsive to opioids. It's probably the best tool there is for acute pain, but there's no studies that show that chronic pain is effectively managed by opioids.
Okay. Let's take a look at what a physician's responsibility is now in relationship to this law. And I think we actually have a full screen we can pop up here to give people a better idea. There are a lot of things here that doctors have to kind of follow along with the law in order to prescribe an opioid. They have to register with the DEA. They have to complete a 2 or 3 hour course on prescribing. They have to register that they treat chronic pain, document the patient's pain, and then actually like a written plan to treat it. This is important. They have to check the state database now to see if a patient has other narcotic or opioid prescription. Check the patient's photo ID against medical records, and then enter that prescription into the database by the end of the next business day. This is a lot that doctors are being asked to do. Do you think this is going to preclude some doctors, maybe not necessarily pain management doctors, but other doctors, from actually prescribing opioids to begin with?
I believe it can. A surgeon, obviously operating on somebody, is going to prescribe an opioid. I mean, they have to. It's not going to deter them. But maybe for a minor sports injury, this will deter a physician. But a minor sports injury might be better treated with another class of drugs, such as ibuprofen. So I'm actually in agreement with the regulations. I think it will save lives, maybe not right away, but if opioids lead to addiction and there's less opioids around, less potential for diversion or accidental use, it'll be good, but it'll take some time.
And Dr. Kjelson, I want to talk to you a little bit more. I mean, this is something that hits home to you because you were telling me earlier your mom died back in 2009 because she was addicted to opioids. How did she get there, and how do other people get to that point?
Well, I think we need to better understand the healthcare system, and I won't go too in depth in it, but we have a systematic problem. You know, it's not, and I was talking with our physician here, that it's not just physicians, which many people point the fingers. I would be one to point a finger if that was the case. And it's not pharmaceutical companies alone. It's a systematic approach. We didn't have assessment levels in between. So when a patient in 2009 or prior to went to their physician and got a prescription for opioids for legitimate reasons, they could then go to another physician, and that physician didn't have access to see. And the pharmacist didn't have access to see in what we have today, which is the prescription drug monitoring program. And I think HB 21 is actually going to help advance that. I know there is a lot of burden, which we discussed about, and I'm sure we'll get into, but the PDMP, I believe if that was around at that time, it wouldn't have...
PDMP is the patient...
prescription drug monitoring program. I believe if that was around in 2009, my mother would have been saved and helped. But, you know, just a common case, she got addicted and even started to sell the narcotics because that's the kind of lifestyle and traits that come along with it.
Sure.
And you start to understand the value of a pill that's worth $35 in cash. So, you know, there was a systematic approach because everybody's responsible. The pharmacist could have done better education. The physician could have had more time to educate.
Yeah.
You know,
so overall, it's education. I've heard both of you say that. Unfortunately, right now we're out of time. Thank you both so much.
Thank you.
Continue this ongoing conversation. I'm sure we'll have you back. And you have a comment or a question about the new opioid prescription law or anything that we've discussed here today, send us your thoughts via email or go to our Facebook page at Your South FL. You can send us a video or a message about topics impacting you and the community. As always, we look forward to hearing from you.